Well, for those of you in the virtual room, I'm Gary Lerner. I'm the chair of the Ethics Committee. It's my honor and pleasure to welcome our distinguished lecturer, Dr. Thaddeus Mason Pope, this morning, who's going to talk about a very interesting, timely, and controversial topic, brain death. Dr. Pope got his JD and PhD at Georgetown. He has a doctorate in philosophy and bioethics. He is currently the director of the Health Law Institute and a professor of law at the Mitchell Hamline School of Law in St. Paul, Minnesota. He has authored over 200 publications in leading medical journals, law reviews, bar journals, nursing journals, bioethics journals, and a number of book chapters. He co-authored a 1,500-page tome entitled The Right to Die, The Law and End-of-Life Decision-Making, and he runs a popular blog called Medical Futility Blog. Dr. Pope has co-authored clinical practice guidelines for medical aid in dying and policy guidance on ethics and critical care for major professional medical societies. And apart from his scholarship, he served as legal consultant and expert witness in court cases involving end-of-life treatment. And there are a number of very high-profile cases in pediatrics, which he may allude to. So in short, our distinguished speaker is one of the most learned and articulate authorities on the subject of this morning's lecture. Although many writers, poets, philosophers in the past have eloquently addressed the topic of death over the ages, one stands out over the others in regard to Dr. Pope's subject this morning. And yes, of course, that would be none other than Miracle Max of The Princess Bride fame, who pointedly pronounced the man in black as only mostly dead. So I turn it over to you, Dr. Pope. Take it away.
Thank you, Dr. Lerner. Good morning, everybody. Thank you for having me. It's a pleasure to be with you. So I'm going to talk, my title, Brain Death, Fundamental Principles and Growing Ethical Challenges. So I don't have anything to disclose. And I posted the objectives for you. So let me start with an active case, a case that's still unfolding actually this morning. So this is happening at Texas Children's Hospital in Houston. The patient is Nick Torres, a 10-month-old baby. And the case starts back on September 24th. And on September 24th, Nick is getting a bath, and it's his 16-year-old brother, his older brother, that's giving him a bath, who unfortunately stepped away to go get a towel, and Nick was submerged while his brother stepped away. So Nick's admitted to the hospital, and a few days after he's admitted, clinicians administer a brain death exam and determine that Nick is in fact dead on neurological criteria. But the family doesn't accept that diagnosis, and they definitely don't accept the consequence of that diagnosis is that Nick will be withdrawn from mechanical ventilation. So they go to Harris County Court in Houston and get an injunction prohibiting the hospital from withdrawing mechanical ventilation. Now that TRO, temporary restraining order, expired, and then what the family did is they appealed, they went up to the Texas Court of Appeals, where the case was just finished. The parties were just briefing the court yesterday, and now we're waiting for the court to issue its decision. But it's very likely that no matter what this court rules, that if the family loses at this level, they'll take it up to the Texas Supreme Court, which will do the same thing, which will stay, right, preserve the status quo until they can decide that case. So it could be this could go on into October and November, right? Right now, of course, today, it's October 9th, right? So already, since he's been determined dead, he's remained in the ICU for 2 weeks after being determined dead, and that could continue for weeks or even months into the future. So that's the sort of case we're going to talk about, okay? I've been invited to a lot of children's hospitals over the last few years. What I'm usually asked to talk about, not today, but what I'm usually asked to talk about is this question, which is when may or should or must a clinician stop life-sustaining medical treatment without consent? Right, so there's a situation where the parent won't consent when the physician thinks that they should. In other words, the clinician thinks that the appropriate path forward for a critically ill child is comfort measures only, but the parents want to continue life-sustaining medical treatment. Right, and there's another case in Texas from Cook Children's, which illustrates this case. It's even more high profile, involving Tinsley Lewis, because this case is now before the Supreme Court of Texas. The difference is that Tinsley absolutely is still alive. It's just that she's catastrophically critically ill, and the clinicians are suffering a lot of moral distress by being forced to treat her pending the outcome of the court case. So what we usually have, like with Tinsley Lewis, is what we call a medical futility conflict. And that's often about line drawing, right? Drawing a line between what's appropriate and inappropriate medicine, or between what's advisable or inadvisable, or between what's proportionate versus disproportionate treatment, or between what's called beneficial or non-beneficial treatment. We have a lot of vocabulary in this space. Or what's inside the standard of care and what's outside the standard of care. In Europe, they would say it this way. They would say what's therapeutically obstinate and what's not therapeutically obstinate. These lines, though, these lines that we use in medical futility conflicts are pretty fuzzy and pretty gray, and we don't have a lot of clarity here. But generally, in most parts of the United States, so long as the child's still alive, and we're calling it a medical futility conflict, generally, that's a family decision. In contrast, once the patient has been determined dead, it's way more straightforward, and that means that things are generally within the scope of clinician control and outside the scope of the parent's decision-making authority. Right? Once the patient has been determined dead, withdrawal is okay, and you don't need consent. Because brain death is death. Right? And this is well settled in all the guidelines. Just a couple examples from the American College of Physicians. Once a patient has been determined dead, medical support should be discontinued. All medical intervention should be withdrawn. Right? That's the consequence of death. Unless, of course, there's going to be organ transplantation. So this morning, we're going to talk about brain death, which used to have this bright, clear line and have a relatively straightforward decision-making pathway. The line between life and death used to be really bright and clear and sharp. Unfortunately, over the past 4 or 5 years, it's become a lot more gray and a lot more fuzzy. If you just look in the past few weeks in pediatrics, in the American Journal of Bioethics, in JAMA Neurology, you see a lot of articles about conflicts around brain death, especially pediatric brain death. In a few days, we have the big, I guess it's the biggest bioethics conference in the United States, ASBH. And there are hours and hours and hours of sessions on brain death, right? And you never had that at this conference a few years ago. So what's different today, right? What happened to brain death, which used to be relatively sharp and clear and stable, and now is not? So here's the roadmap for the session. And I'm going to go in 4 parts. Part 1, just give a quick introduction to brain death. Part 2, I want to describe how resistance to brain death is growing. how parents are pushing back. Part 3, to talk about what are the consequences of that resistance for the hospital. And then finally, to describe 4 different types of attacks. These are ethical, legal attacks on brain death. But first, let me take you back to 1968, okay? The Beatles are still together. They're still performing. Picasso, still painting. Andy Warhol, still painting. Martin Luther King, still marching. Richard Nixon is the president. Bobby Kennedy running for president. And this is Donald Trump in 1968. In 1968, when the year started, there was only one way to determine death, right? And that was by the irreversible cessation of circulatory and respiratory functions. But by later that year, by the second half of 1968, we have this JAMA article by a committee at Harvard outlining a second, additional, alternative way to determine death. And that was by neurological criteria. And when they wrote this article, one thing they wrote is no statutory change in the law should be necessary. And at least with that part of the article, that was definitely just wrong, okay? And that's because clinicians are really risk averse, legally risk averse, right? They want certainty and they want clarity in this space. And that's especially true for transplant surgeons who at this time were concerned. There were some criminal prosecutions and lawsuits that by procuring a heart, for example, you weren't procuring it from a dead patient, but you actually caused the death by taking the heart. So they wanted clarity. And so starting in the 1970s, states started recognizing that brain death is legal death. Unfortunately, throughout the 1970s, the states took 5 or 6 different types of approaches to how they specified what brain death was. And that's not good, right? There was this high level of variability, right? It would be not good is if you cross the line, the state line from Nebraska to Iowa, that would change the fact about whether a patient was alive or dead, right? That just by crossing a state line, that shouldn't change the fact of your life or death. So in this space, uniformity, national uniformity, was thought to be really, really important. So Jimmy Carter calls together a presidential task force, and they issue their report in 1981. And this is the report called Defining Death. And what this report outlined ultimately became known as the Uniform Determination of Death Act, the UDDA. And it says, and this is the law in Nebraska, it says an individual is dead if they've sustained either irreversible cessation of circulatory and respiratory functions, the traditional definition, or irreversible cessation of all functions of the entire brain. In other words, brain death is death. So that's written right into the statute. And it's been adopted in Nebraska and pretty much in every U.S. jurisdiction, every state, D.C., Puerto Rico, Guam. And this has been legally settled since the 1980s, right? We've had 40 years of a relatively stable consensus on this point. But over the past 5 years, that has become increasingly unraveled. And that's what I want to describe for you, what's happening. Let me give you a quick analogy. Around the same time, remember, brain death invented in 1968. As you'll recall, about the same time, we sent people to the moon, right? One of the things we did, July 1969, when we sent people to the moon, is we collected thousands of pounds of moon dirt and moon rocks, right? What did we do with those when Apollo 11 brought those back? We put them in a vault, and they've remained there ever since. Like, nobody ever studied them. They were put into like an air-sealed vault. Just really, really recently, NASA just said, oh, we're going to give some grants to various US universities to actually study these rocks. And so like those moon rocks, it's just now, 50 years later, that brain death is really coming under examination and is being put under the microscope in the same way that those moon rocks that just sort of sat there for a long time are also coming under the microscope for the first time. So, growing resistance to brain death, right? More families are disputing brain death. Couple data points. This was a study of 200 US neurologists from a few years ago. 50% of them reported that families request organ support after brain death. You have similar reports separately published from San Francisco General, from the Cleveland Clinic, that families reject a diagnosis. They're asking the treating clinicians to deviate from standard procedures, which is, of course, to withdraw organ-sustaining treatment. There's more conflict, and a lot of these cases are going to court. This is just a small subset of the cases that have gone to court in just the past few years. And as you can see, they're almost all pediatric cases, right? And this is all across the country, right? This is from California to New York to Philadelphia and everywhere in between. A lot of conflict, brain death cases going to court. Why are they going to court? Why is this happening? Well, here's a few reasons. One is there's diagnostic confusion, right? Brain death is a sort of a tough diagnosis to swallow and accept because the patient kind of looks alive because the mechanical ventilator is perfusing them and they look like they're breathing, right? And families say things like, well, since there's a heartbeat and they're warm, therefore they're alive. And they think, well, he's in a coma with rehab, with time, he'll get better. So it's sort of like a sleeping beauty thing. They think, oh, they just need to wake up. On top of that, confusion, there's linguistic confusion. Even the term brain dead implies that they're not really dead. They're just brain dead, right? We don't use the term heart dead. We don't modify dead when we're talking about cardiopulmonary death. Give you a few examples from Nebraska. These are just headlines, right? 13-year-old clinically dead after school fight, right? Oh, he's just clinically dead. I mean, that adverb implies they're not really dead. They're just clinically dead. Why put the adverb in there? This was a case from Omaha. Brain dead Nebraska mom, Carla Perez, kept alive to deliver baby. If she's brain dead, she wasn't kept alive, right? So you have headlines like this that sow confusion in the community. This is a headline. This guy's, I guess he's a basketball announcer, Scott Marr, for the Creighton basketball team. I don't know if you could read the caption below the photo, but it says, thought to be brain dead, Scott Marr awakened, right? Brain dead people aren't supposed to awaken. And then when the press reported on this, of course, they call him Miracle Man. And if you look at the back of his hat, that's what his hat says too, right? So this is further sowing confusion about what brain death actually is, right? It's no wonder people are confused. So you have diagnostic confusion, you have linguistic confusion. What else? There's mistrust, right? We know from these studies like the IOM to Error is Human report, right, that there is a lot of medical error. And then the more recent studies from BMJ, right, confirm that medical error is the third leading cause of death in the United States. 400,000 deaths from preventable medical error every year. And some of those medical errors are brain death medical errors, right? We have well-documented cases like Zach Dunlap, who was confirmed dead and now is a college student. You have headlines in the LA Times, close call in death ruling of potential organ donor. Similar headlines in New York, patient awoke as docs prepared to remove organs. And then you have super high profile media physicians like Sanjay Gupta, who has a book called Cheating Death. And in the book, he talks about this line: they were declared brain dead. It was written in their charts, but here they are sitting up talking to me, right? So this is further sowing doubts and mistrust. Now, some of those errors, or probably most of those errors, were somebody just made a mistake in how they administered the brain death tests. But there probably are also what you might call some more culpable errors as well. So there have been cases in the courts involving transplant surgeons who allegedly crossed the line and hastened the patient's death in order to procure their organs. And in fact, there have even been significant settlements in cases making these allegations with some OPOs. So you have mistrust, you have both diagnostic and linguistic confusion. What else? What else is causing these conflicts? Well, there's just a general phenomenon of what's called taphophobia, right? Which is the fear of being buried alive, right? Which is well captured in this book by Edgar Allan Poe called The Premature Burial. And at the time of Poe, in the mid-1800s, we invented and started using all sorts of tools, right? Because people were afraid, I don't want to be buried alive. So we'd use a tool like this that would like pinch the person. So if they were alive, they would wake back up or scream out in pain. So we started using tools like this. This is one where you take tobacco smoke and you blow it into the rectum of the patient. And this is where the expression blowing smoke up your ass comes from. What else did we invent? Like we had these when somebody was buried, there would be a string that would go back into the coffin. So if the person woke up in their coffin, they could pull the string, and then that would either wave a flag or ring a bell, and then somebody could come and dig them back up. And this is where the expression comes from, saved by the bell. Right? So we invented these things. People want to be sure, right? We don't have those 1840s things anymore, but people still want to be sure. What else? Religion, right? There are some religions that are not, don't accept brain death as death. We'll come back to that one. What else? Miracles. There's a big belief in miracles in the United States, right? There's the story of Lazarus, right, in the Bible. And this has been studied that despite even the physicians giving a prognosis, still, even with that prognosis, 57% of Americans would say, well, I still think there might be a miracle. There's also more organized opposition to brain death. So there are pro-life advocacy organizations that traditionally have focused on beginning of life issues like abortion and contraception, but now are focusing on helping families take hospitals to court in brain death conflicts, like this organization, like the Pacific Justice Institute, and others. And then finally, and this is probably what I'm going to focus on later, is the very concept of brain death is probably more vulnerable today than it's ever been. Okay, so there's more resistance, and those are some reasons for why there's that resistance. What happens? Well, one thing, and I started this presentation by telling you about the Nick Torres case in Houston at Texas Children's, right? He's already been in the hospital for 2 weeks after brain death because the courts told the hospital, until we resolve this lawsuit, you need to keep ventilating him and so forth. Other cases, though, have lasted 9 months or longer while this works its way through several levels of courts. And that's a long time, right? Hospitals they put in, when the CEO comes to testify in these cases, have estimated that this costs them $10,000 a day. But that's just the financial cost, right? Probably the more significant thing is it harms innocent third parties, right? As you guys know, and there's probably a couple reasons it harms innocent third parties. One is PICUs are often full, right? Which means if you have a dead child there, that means that bed is not available for somebody else who is deprived of the opportunity to benefit. So they're either sent farther away or they're in a less safe setting. And then second, what about organ transplantation, right? We've had record years of having more than 10,000 donors. Of course, that's not enough, right? It's still a way shortfall of the demand for organs. But if public trust and public confidence in the brain death diagnosis falters, then it's likely that so will the donation rates. And then the gap between supply and demand will increase rather than decrease. So that's sort of the background of what's, that there is more resistance, some reasons for why that resistance is. But what I want to describe now is what are the arguments that they make, right? How do you convince a court that the hospital should continue to treat somebody even though they've been determined dead? So what are the actual arguments that are being framed here? And I want to take these from there's 4 types I want to talk about, but I want to start with the least serious and then move to what's the most serious problem with brain death. So this is the first attack, and I'm just going to call this just confusion and mistrust. And there's a lot of cases that manifest this kind of conflict. Let me give you just one example. Now, this is an adult case, but I think it illustrates the point pretty quickly. This is from Anaheim in Southern California. So the patient was Lisa Avila, and what happened is she had an ectopic pregnancy, but that had been missed as the diagnosis. It ruptured and she died. So clinicians determined that she is dead on neurological criteria, and now they are planning to withdraw ventilatory support. The family says no, right? Don't do that. We don't agree with that. And in fact, we don't believe you, right? Because you were wrong about the ectopic pregnancy. You missed that, right? You missed that diagnosis. So you're wrong about that. Maybe you're wrong about this too, right? We really don't trust your diagnostic accuracy. So they go to court and get an injunction prohibiting the hospital from removing the ventilator. And that buys them some time. And in that time, they get a neurologist who's not affiliated with Anaheim Regional, an independent neurologist who comes in and says, yes, Lisa really is dead. And they accept that, right? Because they're hearing it from an independent, neutral source. And so this was, I think, a nice example where the law bought time for the family to accept or at least to confirm the diagnosis that they're hearing from the treating clinicians that they don't trust. But there are other tools to mediate these sorts of conflicts where there's just mistrust or confusion. One is, like, as I said, don't use the term brain death. Like, we can use it on this webinar here, but don't use it when you're talking to families. Also, unfortunately, there's a real lack of good patient literature that graphically explains what exactly brain death is. This is from the, JAMA has a patient page. I don't know if this is the best tool, but unfortunately, most of the tools that are available for patient education about brain death come from OPOs. And I think maybe it would be better if it came from a source that wasn't perceived as interested or as having a bias or conflict of interest in the outcome. The test itself, of course, is mostly just a simple clinical bedside exam, and therefore is observable by the family. And there's some evidence to show that might, if they're able to watch the test be administered, that might make them more trusting of that exam. And that relates to similar evidence of being able to observe CPR. And then finally, on the trust point, some points about trust are relatively easy to keep. In the Nick Torres case, which is the one that's still unfolding in Texas, they actually, in their complaint, go on and on and on about things that really made them really broke a rift in the communication between the parents and the clinicians. In just a couple simple examples, his name is Torres, Torres, but on his chart in his room, they spell it Torez. So they use a Z instead of an S. And the birth date in the records is not his actual birth date. And so these sorts of things really annoy the parents and cause them to feel that the hospital isn't sufficiently respectful of them or of the patient. So that's the first attack. That's the first attack on brain death. Attack number 2, parents want a religious exemption. They have that in New Jersey. And in New Jersey, the law says that death shall not be declared on neurological criteria if that would violate the personal religious beliefs of the patient. So if you have a religious objection, you can't be declared dead on brain death criteria, right? You may satisfy brain death criteria. We could do the tests. You may satisfy them, but we can't declare death. We can't say that you're dead until you satisfy death by cardiopulmonary criteria. Now that rule, what you might call a flat-out exemption for brain death, has been rejected everywhere outside New Jersey. So New Jersey is absolutely unique and alone in this. But that kind of exemption is asked for quite a lot. It's being asked for right now in the Nick Torres case in Texas, for example, right? CHOP had 2 cases, Children's Hospital Philadelphia had 2 cases like this in the summer of 2018 involving this patient and this patient asking for religious exemptions. And by the way, right, think of where Philadelphia is. It's right across the river from New Jersey. So the mothers were literally saying, just let us take him across the bridge, right, to New Jersey. And in one sense, the Delaware River here, which separates Pennsylvania and New Jersey, was kind of framed in both of those cases as the river Styx, because it's literally separating the underworld from the world of the living. Because if they went to New Jersey legally, the child would be alive again. This has happened in other children's hospitals. There's a children's hospital in Washington, D.C. Orthodox Jewish parents say, we don't believe in brain death, so you can't declare our child dead on neurologic criteria. And that case goes to court, and the court says, well, unfortunately, you're not in New Jersey, you're in Washington, D.C. So they lost that request. And that's the same result you see in a Michigan case involving a Muslim family, in Massachusetts with a Buddhist family. And other states have considered these exemptions. California considered legislation, New York considered legislation. So a lot of states have considered it, but everybody rejected it except New Jersey. So New Jersey is the only place where you have an exemption, a religious exemption from brain death. But the cases keep coming, right? They keep coming, right? There was a case in California. This is a brand new case involving this baby, Israel Stinson. His family sued the state of California, saying, we're Christians with firm religious beliefs. So long as the heart is beating, even if it's just because of mechanical ventilation, so long as the heart is beating, the patient's still alive. And therefore, if you remove the cardiopulmonary support, then that would be an unconstitutional interference with our First Amendment freedom of religion rights. Just 2 weeks ago, the U.S. Court of Appeals for the Ninth Circuit rejected that claim. But the point is, this is being asked for quite a bit. And there was also a new case in New York on this. And like I said, this is also an issue in the Nick Torres case. And we're probably going to see more of these religious exemption cases because, as I said, there are pro-life advocacy organizations very interested in pushing this question. So that's the second attack on brain death. Attack number 3. This is the question. And this has been, if you look in the recent issues of Pediatrics, in JAMA, and American Journal of Bioethics, it's been written a lot in just the past 8 weeks. Must clinicians obtain consent for brain death tests? So what happens here is some try to prevent the brain death diagnosis. Actually, so in the Torres case, again, I'm just using this because it's still happening, right? One of the things they asked the trial court to do originally was prohibit the hospital from even doing the confirmatory apnea test, right? Prevent the hospital from even determining that he was dead. The court refused to do that, but they asked for it. Why are people asking for that? Well, what are clinician duties after brain death? They're super limited. Consent is not required to withdraw life organ sustaining treatment. Once somebody is determined dead, they're really not a patient. And if they're not a patient, then there's no treatment duties. There's no treatment relationship. You can't have a treatment relationship with a non-living person. So although all those duties are sort of turned off once death has been determined. This is a really bright line rule in the law. In other words, there are no post-brain death treatment rights that the parents have. So they focus on their pre-brain death treatment rights. And they have some of those, arguably. And what people really focus on is the apnea test. And that is the final confirmatory test. And that's built into both the adult guidelines from the American Academy of Neurology, and it's built into the pediatric guidelines as well. But what we have are more family refusals, right? Don't do the apnea test. They're almost all pediatric cases, so we might just call them parental refusals, right? The mom is saying, no, don't do the apnea test. And if you can't do the apnea test, then you can't determine that the patient's brain dead. And if you can't determine that the patient's brain dead, then your treatment duties continue. Now you might say, hey, Professor Pope, that really is pretty much, that's pretty much looks like the New Jersey religious exemption, which is we can't declare them dead. Now in New Jersey, it's because the law just says you can't declare them dead if they have a religious exemption. Here you can't declare them dead because you can't even determine them to be dead because you can't do the necessary tests. It's effectively an opt-out of brain death. Now, you might say, hey, if you can't do the apnea test, we can just do some ancillary tests instead because the guidelines have another pathway for that. But you're going to run back into that same consent question, which is, do you need consent to do those tests? So the core question is, must clinicians honor the refusal? Do clinicians need consent to do the apnea test? And there's a big split, and it continues to grow, right? Some places say yes. Let me just give you a couple cases. There's a case of Alan Calloway. This is a case from Billings, Montana, and a little 6-year-old drowned, or according to his family, almost drowned. And he goes to the hospital. The hospital does the bedside clinical exam, thinks that he's probably dead, wants to do the apnea test to confirm. Mom says no. So the hospital goes to court in Montana, says, Judge, we have a patient in our hospital and we need to know, are they alive or are they dead? It's kind of important information. We need to know that. So let us do the apnea test. The court says, no. Your request permitting testing is denied. The mom has sole authority to make medical decisions, including brain functionality exams. So they take Alan, eventually transfer Alan home mechanical ventilation, and as far as I know, he's still there today. So do clinicians need consent to do an apnea test? Montana said yes. Kansas also said yes. There's another boy, also a drowning victim, also got a court injunction prohibiting brain death tests. Same thing in California. Another boy, also drowning, goes to the hospital. Family refuses the apnea test. Family goes to court, gets a court order prohibiting the hospital from doing the apnea test. Same thing with this case in LA. do clinicians need consent for the apnea test? So Montana, Kansas, California courts all said yes. And by the way, that's a plausible position, right? Because normally you can't do things to a patient without consent. And the apnea test is kind of invasive. Now, other places have said, no, you don't need consent. So in Virginia, case involving Miranda Lawson, there's a case from Richmond, little 2-year-old choked on popcorn, and the clinicians do the bedside clinical exam, think she's probably dead. They want to do the apnea test to confirm. Dad says, no, can't do the apnea test. In fact, writes this little note, tapes it to the bed. Removing life support will cause death. That's murder. That's against the Christian faith. The hospital goes to court, says, judge, let us do the apnea test. This time, the court says, yes, hospital is allowed to administer the apnea test. So Virginia said, you don't need consent. Nevada, interestingly, also said you don't need consent. They actually wrote it into the law. So it's not a court decision. The legislature changed the law. This is the governor signing the law. And what the new law says is determination of death is a clinical decision that does not require the consent of the person's representative. So do clinicians need consent for the apnea test? New York also said no. Georgia said no. So we have a split, right? Some states you say you need consent. Some states say you don't need consent. And again, the cases keep coming, right? There's a number of cases at this children's hospital with this patient, this children's hospital with this patient. And by the way, it's not just courts, right? The neurology community itself is split on this. So a significant fraction of neurologists say, yeah, we should get consent before we do that test. And others say no. That's the third attack. Do you need consent to do these tests? So the final attack, this is the most serious attack. Too much sun coming in. This is the most serious attack. And the question is, are the medical criteria for brain death legally sufficient? And the key case here comes from Reno, Nevada. This is the patient, Aiden Hailu, and she suffered a catastrophic anoxic brain injury during an exploratory laparotomy. And subsequently, clinicians determined that she met the American Academy of Neurology criteria for brain death. Her dad, though, didn't agree. Her dad says, no, she's not dead. He takes this to court in Reno. He loses. Why? The court says, all the clinicians say she meets the AN criteria, so those are the criteria, therefore she's dead. Dad appeals that up to the Nevada Supreme Court, where he wins. Why does he win? What does the Supreme Court of Nevada say? They say, it doesn't matter. It's irrelevant that she meets the American Academy of Neurology criteria because they're not the right criteria. Even though they are the prevailing medical criteria for brain death. Why? Why do they say that? Two reasons. One is, what does the UDDA say? Remember, again, the UDDA, that's the brain death law in Nevada, also the brain death law in Nebraska, right? The determination has to be made in accordance with accepted medical standards. But there's a whole ton of literature showing that there's massive variability, and many, many, many hospitals do not follow the AAN guidelines. The AAN itself has lamented this fact repeatedly in writing a whole bunch of articles about how to improve uniformity and compliance. So there's variability in how many physicians. Does it need to be a critical care physician? Can it be any MD? How exactly are the tests administered? There's massive variability across a number of dimensions. So Aiden may have met the AN criteria, but the AN criteria don't do what the law requires. They don't do what the law requires. They're not the accepted medical standards. So the court really threw brain death into doubt. People were really unsure about how are we? So we thought the AN were the right criteria. What criteria are we supposed to use? The legislature steps in and fixes this, and they say, we'll tell you what the accepted medical standards are, and they name them by name. So for adults, it's the AN, and for pediatrics, it's the AAP. So they just wrote it right in the statute to eliminate all uncertainty. But that didn't solve all the problems, because the Supreme Court also, and this is not just a problem in Nevada, it's a problem everywhere, also said that the AEN doesn't measure what the UDDA requires. The UDDA, and this is the law in Nebraska, requires irreversible cessation of all functions of the entire brain. But brain dead people still do stuff, right? You know, because you had this case in Omaha, you can have somebody who's dead and they can still gestate a fetus. We also know that dead people can heal wounds, fight infections, mount a stress response, grow, sexually mature, and regulate temperature. And these sorts of issues were acknowledged in the President's Bioethics Council report a few years ago. It appears that the AEN only measures the cessation of some functions of part of the brain, and it's supposed to measure the cessation of all functions of the entire brain, right? There's a gap between what the medical criteria are measuring and what the legal standard requires to be measured. So the UDDA, of course, is silent on specific diagnostic tests and procedures, right? The lawmakers were smart enough to defer to the medical profession. You guys figure out what tests to administer. But that discretion that was given to the medical profession is not completely unfettered, right? The medical criteria have to measure what the legal standard requires to be measured, which is irreversible cessation of all functions of the entire brain. It's pretty categorical, right? And unfortunately, it looks like we're only measuring most of the functions of most of the brain. We're supposed to be measuring total brain failure, but we're basically only measuring what you might call massive brain failure. The medical criteria have drifted too far away from what the statute requires. Sort of got off the leash, so to speak. So the legal standard may demand more than the medical criteria. And the board, a really fine point on this, last year, the American Academy of Neurology published a position statement saying that neuroendocrine function may be present, and that's not inconsistent with the whole brain standard of death. So that may continue even after a patient has been determined dead. Well, the UDDA, again, says you have to measure all functions of the entire brain. If you're going to ignore the hypothalamus and the pituitary gland, they appear to be part of the brain, right? So you can't, at least as far as the law is concerned, ignore those functions. So you can be medically dead, but not legally dead. So let me just end with one other case. This is a case of a sort of blunt force trauma to the head. The patient was the Wicked Witch of the East. What happened is a house in a tornado fell on her. And so the Munchkins were all celebrating this, right? Ding dong, the witch is dead, the witch is dead. But the Munchkin mayor comes out and says, hold on, guys, hold on, right? Wait a second. We've got to verify it legally to see if she is morally, ethically, spiritually, physically, positively, absolutely, undeniably, and reliably dead. So they get the Munchkin coroner. So he comes out in blue here, and he says, and he checks out the Wicked Witch of the East, and he says, she's not only merely dead, she's really most sincerely dead. We need certainty and clarity in this space, right? For a long time, the debate has been academic. This is in all these bioethics journals, in full book-length treatments, like this one by Bob Trug, other book-length treatments. A really distinguished neurologist, ethicist, Jim Burnett, observed a couple years ago, the critics and the skeptics have not gained much traction with lawmakers. That may have been true when he said it, but it's a lot less true now. This is not just an academic debate, right? The courts and legislatures are really grappling with this. It's a public policy question, right? The line between life and death needs to be bright and clear and sharp. And unfortunately, it's now a little bit gray and a little bit fuzzy. We need, as some might say, to build a wall between life and death, right? And let me just end by telling you, we're working on this. So there's an entity called the Uniform Law Commission. basically drafts model legislation that the states may then adopt. They're the ones that drafted the UDDA in the first place back in 1981. So with a couple co-authors, we petitioned the Uniform Law Commission to consider revising the UDDA to address some of these problems that I flagged for you. In other words, to put out a revised Uniform Determination of Death Act, or UDDA. And they did that. So they form a study committee, and the idea of the study committee is they'll figure out, do we need to revise the UDDA? And they'll issue their report by July. If they say we should revise the UDDA and the ULC commissioners accept that, then they'll form a drafting committee. And their job will be to actually draft the actual language for the statute. And they may address the stuff that I talked about. Do we need consent? What do we do with religious objections and so forth? And then they should get that language out by July 2022, at which point all the state legislatures, including Nebraska, consider, do we want to adopt the revised Uniform Determination of Death Act to replace our current UDDA? Now, that's not going to eliminate everything. There's still going to be confusion. There's still going to be mistrust. But amending the law will go a long way toward reducing variability and increasing certainty. Thank you. So I am pulling up the chat.
Hello, this is Jeffrey Solomon. Am I okay to go ahead and ask a question?
Yeah, I was just looking if there was chat questions, but yeah, go ahead. I don't see any in the chat.
So I'm one of the pediatric critical care physicians, and one of the areas that I feel we have potentially exacerbated this issue is with our own linguistic error in calling it an apnea test. In my perspective, I feel that this is part of my routine examination of a patient on a ventilator, is to evaluate whether or not they are able to breathe. And when you get admitted to the hospital, you sign a consent that says we're allowed to perform examinations. Do you feel that our linguistic use of test versus calling it part of our examination has led to some of the errors that we're seeing today?
Well, so to be fair, and you may disagree with me on this, but my look at the literature shows that this is a test that involves some risk, right? So I think the apnea test is probably different from some of the other brain death tests, right? Because some people have argued, I think relatively cogently, that there is some risk of exacerbating the patient's brain injury just by doing the apnea test. And therefore, it seems to be that it's a test in a different category from tests that aren't invasive and don't pose risks, right? And normally, you don't, patients get to decide if they want, how they want to balance off risks and benefits. I mean, so does that, so I don't know that, what I don't know, if I may be getting your point, that there's a big difference between calling something an exam or a test. But I think the argument for the apnea test is, I guess, stronger than it is for an argument that you need consent for ancillary tests, which maybe don't pose the same kind of risks.
Right, yeah, that helps, thanks.
Hi, my name is John Sparks. I'm a retired neonatologist. I'm interested in your thoughts about how these might apply in a newborn setting. The determination of brain death in neonates, particularly in small premature neonates, is much more complicated. And wonder if some of these issues are playing out in the neonatal sphere as well as the critical care sphere.
So, thank you. So, we have not seen a court case. So, like I said, there are now dozens of pediatric conflicts that have gone to the courts mostly since between 2015 and today, but none I can recall being in the neonatal context. So and you probably know better than me why that might be. But that is that hasn't come up. I mean, there may be conflicts, but they have not escalated into a court setting and become sort of transparent. That makes things transparent, and we could all, everybody can follow them. So I think I guess my answer is no. I'm not aware that's a as conflict ridden as pediatric cases. Do you have an observation on why that might be?
I think I don't know. There's clearly a long history of neonatal ethical problems, and that's permeated the neonatology sphere for a long time. I think the application of brain death criteria to newborns has been something that's been medically much more associated with some degree of uncertainty, and perhaps that has something to do with it. But I don't know. It's a little curious to me that as many ethical problems as occur in the newborn nursery, that they're not also some of these same problems are not finding their way into the newborn nursery, to the neonatal intensive care unit.
Yeah, I mean, actually, it's a great. I'd like to. Yeah, that's a great observation, because I don't know why I haven't seen any of those. Great, thank you. I'm going to think about that.
It's kind of the dog not barking.
Yeah. So let me. I'm going to read one here. Christian Valquier, you mentioned these news articles about brain death miracles are mostly error. Do you think our methods of determining brain death are adequate, or could improvements still be made? So I guess it's worth saying a couple things. One is there's never been a case where somebody correctly determined to be dead using prevailing guidelines was then later found to not be dead anymore, right? So a correct application of the guidelines, there's never been a case that where they didn't work. So in all these cases, somebody was able to find out that it was really clinician error. In other words, the guidelines were good, they just weren't followed. And that's actually one of the real concerns of the AAN, which is our guidelines are good. There's never been a case where somebody who meets these guidelines would then later recover. The problem is when they go out in the real world and see what hospitals are doing, policies at the hospital level don't match the AAN guidelines. And then on top of that, something else has also been measured, which is individual clinicians at the hospitals don't follow their own hospital policies or the guidelines. So there's just massive variability in done. So to answer the question, the methods appear to be adequate. It's just that they're not there's just non-compliance. All right.
Hi, my name is Dr. Elizabeth Null. I'm a third-year pediatrics resident. I sparked a question. I was involved in a case with a family who was Muslim and spoke a different dialect, and there was a lot of communication issues. I was just wondering, kind of, as these cases have continued to grow, and as we are now more cognizant of attempting to deliver culturally competent care, how that's incorporated into, the different ethical committees and boards that, at least when these cases first start to creep up in the hospital setting, what are we doing to attempt to tackle, language barriers, cultural differences that clearly seem to play a role in how families view life?
Thank you. So let me take that in two parts. So one is, right, one thing that the Affordable Care Act did is it mandates on your hospital and every hospital that if you have somebody who has limited English proficiency, you have to use a qualified interpreter, right? You can't use somebody in the hospital who happens to speak that dialect. You can't just use a family member. So I think the law here, at least, I think has helped on the language side, be very categorical. And the Office of Civil Rights at the U.S. Department of Health and Human Services vigorously enforces those limited English proficiency regulations. It's also worth saying that there actually are very, very few people that actually have a religious objection to brain death. Mostly it's the Orthodox Jews, maybe a Japanese Shinto, some American Indians, and maybe some Muslims. So there aren't very many religions that comprise a large percentage of the American public that actually have a religious objection to brain death. But I do think, and therefore I think it would help, and there are studies that show this helps, in a mediation setting, to bring in somebody from that, if your chaplain service doesn't have this expertise, to bring somebody from their religious community to help explain, no, this in fact is, the tenets of our religion don't in fact require this. It's okay. And that often has worked. But the bigger public policy question is if they truly do have a religious or moral or conscience-based objection to brain death, should that be honored? And like I said, New Jersey does honor that, and there's a debate. And Bob Trug and some others said, well, you know, other states should do the same thing that New Jersey does. They haven't yet, so there is no obligation to accede to such a request. But there definitely is a debate about whether we should.
This is Patty Karstens, and I'm one of the moderators from CME. We have a comment on the chat line that I'm going to read, and then I'm going to ask you to comment on it. Is that all right, Mr. Pope?
Yeah, thank you. Sorry, I missed it.
I haven't read it yet.
Oh,
the comment says, we are having an issue with some parents wanting hyperbaric chamber as a way to bring the brain back. It is actually, a UNMC grad is actually selling this to parents on the internet, as well as neonatologist in Indiana who does not believe in brain death. We have actually had parents asked to transfer their children to sites who do the hyperbaric chambers. Personally, as this person wrote, this is voodoo science and a moneymaker, but it has created a lot of problems in several babies over the last few years who we are trying to do brain death exams on. Could you comment on that?
Yeah, I don't know about that specific therapy, but like I said, there is a rather vibrant movement that opposes brain death. Thinks it's a complete fiction, and thinks that that even if you meet all the criteria, that the brain can heal, and then offer different sorts of therapies for that. And I think this is what actually makes the whole issue rather confusing, is because you have people who actually do question the like I said, the stability or the legitimacy of brain death. So you have Harvard Medical School professors like Bob Trug who say, well, there's some problems conceptually with brain death, and at the same time you have other people who also reject it, but don't have really the same kind of scientific or ethical foundation that Bob Trug has. So I think, unfortunately, the fact that it is vulnerable in the ways that I said, meaning it doesn't exactly measure all cessation of all functions of the entire brain, some functions do continue, I think is something that is able to fuel what I guess you might call just quack medicine, because they have more, they are able to claim more legitimacy to their methods given the cracks in the foundation that Trug or Veach or Alan Schumann or others have already identified. So I think this illustrates, I think, one key reason why we need to, I don't know what the right word is, shore up the brain death diagnosis, because when you have actual insiders, quote unquote insiders, acknowledging problems with brain death, I think that adds a lot of fuel to the fire for the people who have, like the ones that you just described. So anybody?
This is Patty Kersons again.
Yeah.
It is 9:01. Thank you so much. I do not have any more questions on the chat line. Does anyone else have any questions? If not, I believe Grand Rounds is concluded for today. Thank you so much for your excellent talk. We really, really appreciated it.
Thank you. Thanks for having me.